Good morning. Welcome back to our monthly live broadcast here from Mount Sinai Hospital and the Endovascular Intervention Divisions in New York. Today we have the pleasure of watching our live operators, Dr. Prakash Krishnan and Dr. Karthik Gujja, live in action, and some real-time case discussion. I am Raman Sharma, your moderator. Welcome. Before we move on to our live case, just a few announcements. We have our next live case coming up again, as always, on the fourth Wednesday of the month, September 22nd, and we look forward to hosting you then. Also, we are excited to mention again our upcoming conference, which we are excited to host you both virtually and live in person. Our upcoming New York Endovascular Summit on October 15th and 16th, with a dedicated fellows course on the day before, October 14th. We look forward to seeing you all at our beautiful venue, ETC venues down in Midtown Manhattan, and both virtual and in person. And on that note, I'll pass it to Dr. Krishnan and the team to begin today's live case.
All right, Raman, the great job, and welcome to our team. I know that you were out in the last live case, so we welcome you to this really interesting live case. We have a case of a very complex aortoiliac bifurcation with very calcified lesion, which is at a very high angle. So the issue is, how are we going to deal with this? And you can see how the contralateral right iliac overrides the left ostium iliac, which is very, very high, highly calcified and highly stenotic. So the idea, so what we decided to do here, just to get started with a great deal of struggle, is to get radial access. Just to be able to image this properly from, can you go scene minus? Just to image this properly and then to understand what's going to be our approach. As you can see, we had a lot of trouble with this type 3 arch, getting the radial pigtail all the way down, but with some manipulation, we were able to get it there. So currently we only have radial access, and we're trying to decide what's the best way to do this. And I think I'm going to have Luke go ahead and present the case, and then we'll take it from there.
Thank you, Dr. Krishnan. Thank you, everybody, for watching.
How are we going to do it?
So we have a 79-year-old gentleman with hypertension, hyperlipidemia. He's a former smoker, and he was actually initially sent to us into the clinic for evaluation for PAD prior to podiatric surgery. And it was a good referral, actually, because when you really talk to him, he says that for a long time he's been having severe bilateral claudication with less than a half block of walking, making him Rutherford stage 3. He's on maximally tolerated medical therapy, tried exercise therapy with little success. On exam, he has 1+ PT pulses bilaterally and only Doppler and the DP bilaterally. And there was an outside ultrasound that noted severe diffuse PAD bilaterally. We actually saw him in the lab last month and did an intervention on his right iliac with shockwave and stenting. He says that his symptoms have improved on the right, and he's back to deal with the left leg now. So these are just some representative images from the last angio. So you see the arch there, and then a dedicated right iliac shot with a very tight lesion in the common. And then he does have significant fempop and below knee disease as well. And so in the back of our minds, we're thinking about being able to deal with this in the future as well. So the intervention last time went without complication. We did shockwave to the common and the external, and then put 2 VBX stents, as you see there, with a good angiographic result. So our plan for today is an endovascular intervention, an ostial moderately calcified common iliac lesion without involvement of the contralateral iliac ostium in a patient with severe bilateral SFA disease. You can see the appropriate use criteria there, as we always mention. And Raman, I'll hand it back over to you.
Yeah, So, Raman, I mean, when you start looking at the film scene minus Luke, when you start, well, Karthik is getting ipsilateral access, the challenge really is going to be is the overriding of the iliac. And I think, this is one of the great controversies in endovascular is, how do you deal with, do you stent both? Do you recreate the carina? What do you do exactly in these type of lesions? So you can see here you have a severely calcified left common iliac lesion, significant gradient last time that we took a look at it. And at this time, you can see that the actual right common iliac is almost at I would say, at a right angle to the ostium of the left common iliac. And the question is, how are we going to be able to place this stent without involving or burning a bridge to going up and over? Obviously, there's a very complicated lesion, so we decided to get multiple accesses. So here we've gotten obviously the left access and the right access, and now Dr. Guja is just treading up a wire here. It'll get stuck in that spot like it did last time, maybe not. So there it is. So you can see the amount of tortuosity that we're dealing with. So what we're going to do, So the idea here would be, do we get dual access? Do we not get dual access? How do we do it? So I mean, I open it up to, I guess, Karthik and you to see what you guys think on how you would approach this. But our plan here is to really get an understanding of how the best way to be able to preserve the up and over option versus, having to stent both iliacs. So that's kind of where we are right now. So let's take a picture.
It sounds as if you've really described the entire scenario. I think that the iliac tortuosity, the angulation, and the degree of disease is complex in itself.
It's very sensitive.
Yeah, because we did
another interesting part to this is that there is a lot further you have to take into consideration regarding the subsequent interventions, because he has such significant infrainguinal disease.
Good. We lost the radial sheath. Looks like. Is it hematoma?
No.
Hematoma? No.
No. It's there. The catheter is there still.
Yeah, we can put a wire down.
Yeah. 1 second.
Give me just a supercore wire, guys.
He's moving
you need
so
to get
much.
the dilator down.
Yeah.
Well, the sheath is completely out.
No, it's fine.
Can you undo it and just take a look where the sheath is out? Let's just take a look here.
Yeah. He's moving so
much.
much.
What is going on? The sheath is completely out. Right?
I got it.
No, it's not completely out.
Yeah, it's completely out.
It's completely out. So, but let's put a wire in, and then
You want the stiff angle glide back?
Yeah.
get a stiff angle glide.
Yeah.
So yeah, we got a little problem here with the radial sheath coming out. So we're going to put a stiff angle glide. But go ahead, Raman, as you were saying.
Yeah. No, it's exactly as you were mentioning. It seems as though just the iliac intervention planned for today is just but one of several steps of several complex interventions. And I think it's a little bit challenging to kind of make a decision today about what the best way to proceed is. And I'll be very interested to hear what your train of thought is, considering that we do know that we have subsequent interventions
We have a
to go.
6-French femoral dilator.
Things to consider from my perspective would be what are the feasible options for alternative access for the other interventions should we have to. It seems as though radial access is proving quite challenging. Whether proceeding for the femoral popliteal disease, without really, as of right now, I guess we haven't fully visualized what the infrapopliteal tibial vessels look like. Would be to maybe decide whether a tibial first access, depending on this. Oh wow, this is that is a very impressive loop. It's a very challenging type 3 arch that we saw on the aortogram.
We'll be okay. Come down.
Yeah.
Yeah, just it's just going to be a little bit.
Yeah, a couple extra steps.
Okay. Now we got to walk the radial out. You want to walk this out now? You want me to walk the radial catheter out now? Okay, radial catheter coming out, guys. Got a nice loop down below.
1 second.
Yeah, a little bit of that's why we do these cases live. Are we out yet?
Not yet.
A lot of resistance.
Yeah.
Wires coming back.
Dr. Gershon, for the audience, you have a 6 French sheath in there, or is it 5/6 slender, or is it the R2P?
We just have a regular 6 French sheet there, but the problem is the wire is now acting up on us. It's okay. We might have to lose access. We deal with it. Ideally speaking, it would have been nice to have this access as we went forward.
I think we can still have it.
Huh?
We still have it.
Is it up?
Yeah, I got the wire.
Okay, we got the wire now.
Mm-hmm.
We just want to salvage the access and then we can deal with it. Yeah, no, it's going to be impossible to get an R2P sheath in here. I mean, because it's just too difficult. I can tell you that for sure.
Too angulated, definitely.
Yeah, arch is too angulated. It's just not a good case. And we were just thinking that we'll just do a diagnostic catheter with it and then take it from there. You got the catheter, right?
Mm-hmm.
Okay.
I got the wire.
Good. Hang on, Roman. Sometimes, yep. I need a scissor, guys.
Yeah, here.
Mm-hmm. Okay. Okay, give me the sheet now.
Yep.
Whoa. What is this?
No, it's just it's
Hold
a
on.
glide wire, right?
Yep.
Probably just stuck to it.
Hold on.
It's a catheter.
Let's just make sure our wire is still there.
Wire is good.
Wire is still there. Okay, we're going to put another. You have to scrub out Karthik in a second.
Yeah, of course.
Let me push this in.
So the wire came back a little bit.
That's okay. We will definitely be able to.
Again, as we always talk about these radial cases, the cocktail to kind of prevent vasospasms. What was in your cocktail today?
We couldn't give verapamil because of his heart rate.
Mm-hmm. Take it off.
We only gave nitroglycerin and heparin.
Mm-hmm.
So this is not a spasm issue. This is just the arch was a really difficult arch. All right, why don't you scrub out now?
Mm-hmm.
No hematoma?
No hematoma.
Okay, scrub
Everything
out.
is fine. We got it on time.
Okay, now give me
The turbo picked up.
So we're going to go back down with the pigtail to go ahead and get started. We've got contralateral access now. Karthik, you need to put a wire in the other side.
I will.
Put a supercore in or something, and let's access the sheath. So now we're just going to go ahead and advance this catheter in very slowly. Hopefully it doesn't prolapse out, which it may. And if it does, we have to deal with it. Let's see.
You put a glide cath probably.
Yeah, well, this is a glide pig. It's just the same thing. I mean, it's not stiff.
Push the wire down and see.
When I get over the arch, you have to push the wire down a little bit. Hold on. Okay, now just put in the wire. Show me the wire distal. Got to watch the wire in the renal guys.
Yeah.
Beautiful.
Okay, I'm going to show you up, okay?
Yeah, you got it.
Relax.
Yeah, that's what he's doing. He's just
relax. Don't move your hand.
I think he's feeling the stress in the.
Good. All right. So the pigtail is back down. Give antibiotics, Liz. Okay. Let's flush this one out. Let me get another glove. All right. So now let's get back to the case. So right now what we're going to do is we're going to get access on the left leg, which we did. We're going to get a supercore up. We're going to put a 7 French destination sheath, but 25 centimeter with markers, which I think is very important to see where we are. Then we're going to cross the lesion. We're going to give more heparin, and then we're going to do an IVUS. So you can see the access again. You can see how horrible the access is, but that's okay. So it's not. Is it high? Yeah, but you're fine. I think you're fine.
Bifurcation
No,
is very
you're at the level of the inferior epigastric, but that's okay. We'll be careful. That's nice. Is there a hematoma, Luke?
No, looks great.
Okay, no hematoma. So right now, what we're going to do is we're going to get us a supercore wire.
I don't think supercore will go.
You won't go? Let's go with the woolly then.
Yeah, I think so. I will
Here's
go
a
with the woolly. Yeah.
Let's put a woolly up. There you go.
In these complex cases, Dr. Gershon, do you find yourself considering to do some form of non-invasive, perhaps like just a duplex ultrasonography to kind of help guide your case planning moving forward regarding access?
I mean, in this case, you will see that get us a 5 French sheet, guys, here, and then what we'll do is get us a what is it called, a JR4 or a aqua tempo 125,
You
and
have
then
a
we're going to
glide cap,
guide.
no?
We're going to
Yeah,
guide
do you
the
want
wire
the-
through.
We have a Navicross if you.
Navicross is fine.
Oh, it's down. Okay. Oh, okay.
Navicross fell on the ground, no?
Yeah. Sorry, PK.
Yeah. Okay, so we're just going to put a sheath in now. Yeah, I mean, we have non-invasive imaging on this, but I mean, axial imaging with the CAT scan, we don't normally do that, Raman. Generally speaking, for these cases, unless we have aneurysm work along with this, I think you need a stiffer. Can you get it in or no?
Yeah, I got it.
Yeah, I can help.
No?
I got it.
You got it in. Okay, good. All right, so now we're just going to go and get this wire up into the aorta. So the key now is we're going to have to image. So what we're going to plan on doing is we're going to go ahead, change out for a 7 French sheath, and then we're going to change out for an 014 Spartacore, and then we're going to run an IVUS through to understand where the morphology of the plaque is and whether the plaque involves the aorta or not. So if the plaque involves the aorta, or I should say the real ostium, go ahead, I got it, the real ostium, I think then we're going to have to change for a bilateral access kind of situation here. Hold on, let me move it up.
Yeah.
So let me see if this wire goes. There it goes. Oh, nope, it didn't go. Give some dive from above, Chief.
Ready?
Uh-huh.
We're hooked up, right? Yeah.
Yeah, hooked up.
Yeah, you can see we're clearly in the plaque. So let me try to torque my catheter.
You want to get the catheter closer?
Yeah, advance the catheter a little bit. Okay, now let's see. Let me try to torque the catheter. There you go. Yeah, give us a glide wire now. Wow.
You want to try an 014?
Oh, I can, but I mean, it's that's why we did this case live. It's a really tough case.
Yeah.
All right,
You want 014? Like a
Straight.
Spartacore?
Let's try with this one first.
It's just soft.
Yeah. Okay.
Or you want-
That's
we
fine.
have stiff.
Yeah,
If it's
stiff
going
might
into
be
the
better,
plug.
but okay, no problem. Wrong end. So ACT was what, Liz? Okay, give another 1,000. 500, Liz. Yeah.
I think 500 is more than enough.
Huh?
500 is enough.
Yeah, that's what I think too. So yeah, Raman, so we're just going to go up with this wire now, and let's see, God willing, the glide works its miracle and pops through. We were able to get through last time with a pigtail. There it goes. Nope. I'm just a little worried.
Puff a little bit.
The previous intervention, there was also bilateral access with
Yep.
IPSI, but the stent deployment was IPSI. Am I correct?
Yeah, oh, there it goes. Nope. Does it go?
You want to go contralateral entry?
I'm sorry?
You want to go contralateral?
Contralateral what?
The imaging. You want to come RAO, open up the bifurcate, open up the ostium. and
RAO
see.
didn't open up the ostium. We took a picture there. All right, give us an 014 wire, guys.
Spartacore.
No, I wouldn't do Spartacore. Give me like a run through or something.
Strange.
Wow,
Huh?
this is really tough.
Oh.
Don't move. All right, give us a run through. What's that, dear? Give me a shaper.
No.
What happened?
No, he's just moving a lot.
Well, last time we got access, we didn't have this trouble, but we might have mucked up the iliac a little bit, which then causes a little bit of difficulty this time. Let's see.
When the pigtail went through, it must have probably.
That's what I'm saying.
lifted up
Yeah.
some plaque.
So that's also another situation. See, yeah, it's right there. There you go. Okay. Gonna follow it up.
Beautiful.
Where's my wire?
You have to still go
Good.
up.
Okay, it's way up. Okay, go now. Now you can go. So we're going to take this catheter up. Yep, there you go. Now we can turn it
Let me
up
get
for
up. Let me get
supercore.
up. Let me get up.
Yes, you're fine. Supercore is good. You're not going any further. Supercore. Now we're going to
Yeah,
put
we
a
have
25 centimeter. Here you go. Now we're going to do a 25 centimeter
Sheath.
sheath. Okay. Okay. Yeah, sometimes the preparation takes a little time.
I think this case is mainly about how to prepare yourself
There you go.
to finish it quickly, right?
Good. All right, 25 centimeter sheath, gang. Right here?
Right there.
It's right there.
It's there on the.
Okay, good. You made a nick, Karthik?
I don't think we need a
don't
nick.
need a nick?
He's
Okay.
going to ooze. His skin is
Yeah,
very,
it's
very.
okay.
Yeah, I don't want to create a hematoma here. So.
So we're going to put the 25 centimeter sheath up. Let's get an 014 IVUS, guys. I mean, 018 IVUS. We'll go ahead, or whatever IVUS she wants to give us. Yep, that's fine. And then, so we're going to need another exchange catheter here to change out the wire. I wouldn't take it all the way up, so take it up to about maybe 25. Just to about 25.
Well,
What happened now?
he's doing the same thing again here.
You pulled it out again?
Yeah, he's just. Yeah, luckily I have loop.
Yeah, here.
So it's good. It's good. It's good. It's
All
good.
right, all right.
It's good.
Type
Because
that down, please.
I kept a loop this time here.
25?
So even if you pulled it.
That's good, right there. Walk out the dilator. No more. Dilator. All right.
That's okay.
All right. So now we're going to go back again with this. This is flush, Luke.
Yeah, flushed.
So we're going to go with the Spartacore here. Don't lose the wire.
Yeah, 1 second.
So now this IVUS is going to tell us a lot, Rob, and it's going to tell us how the ostium is involved and how we should approach it. So if the ostium is truly involved, then what's going to happen is we might have to use some of the coronary bifurcation techniques that we've had in the past in order to be able to do this. And one of the things is whether we use a balloon pullback technique from the left, from the right, I mean, where we put a balloon across the ostium and then put the stent. But we're not going to know all that till we do the shock wave, till we do the IVUS, and then we'll take it from there. So let's get the 014 wire in there now. Luke, I'll put this away. Okay. So the other question also is the question of, what is a modality? Obviously, this is incredibly calcified. We've had a lot of difficulty even getting an 014 wire through. That's fine. Okay, now we'll do the IVUS. And let's set up for the IVUS, guys. Check an ACT, Guja, when Luke walks this out. So we'll check an ACT and then we'll go. Okay, so the IVUS is ready. And I'm going to have Luke just clean up the table a little bit after giving an ACT, or Guja giving an ACT, one or the other.
Yeah, this would prove to be a very interesting bifurcation stenting if you do. I like the idea of just using a balloon protection of the right ostia to help place to nail the ostium of the left.
Yeah. ACT.
Do you also have a plan of IVUSing the ostium of the right?
So the interesting thing is when Luke and I did it last time, we ensured that there was no gradient, and we were able to get rid of the gradient. So we were able to get rid of the gradient, and we double-checked it before and after. We did not IVUS at that time. So I think that the angle of the contralateral may actually help us because we know that there's no stuff there. So now we're going to go forward with the IVUS here, and then we're going to go live. And then once we go live, we'll see where it is. Where's your IVUS? There it is. Okay, there's your IVUS. Okay, good. Okay, so is that the aorta?
Yeah.
Yeah, that's
Can
the
we
aorta.
increase the gain, please?
Can you increase the gain and make it look
Increase the diameter.
Make it look like a reasonable.
And increase the diameter.
I think
The diameter
is max. That's an 014. That's the problem.
Yeah.
That's fine. That's fine. That's fine. I think we're okay. This is the aorta. We know that.
No, stop. Go up, please. Good. No, go. Okay, record this, the aorta. Come down. So you can see here's the aorta still.
Right,
there's your iliac ostium that's very, very tight. Oh, so just actually below the ostium is really, really tight. So you know what? Let's go back up. Okay, stop it. Let's go back up a little bit. Okay, let's go back up a little bit. Good job. Okay, now what I'm going to do is I'm going to inject, and we're going to do a fluoro save exactly on the spot. Walk it back. Okay. So IVUS, see how IVUS is identifying. That's the ostium, but it's definitely tight there. So fluoro save that. So that's the spot. So you can see now it's truly aortosteal. So we're going to have to deal with, we're likely going to pinch the contralateral side unless we balloon protect it. Or the question now is, do we just kiss?
So this is your right at the ostium, right?
That's right at the ostium. So you can see the IVUS really helps you to identify.
So roadmap it.
Roadmap. Yeah, but the question now is we need to discuss. So let Luke go over some of the techniques, Flora. while we talk about this?
I think it's okay. I think
Okay.
it's a huge aorta.
Yeah, let's see.
Yeah.
Pull it back. We'll decide. Go ahead, Luke. What do you think?
Yeah, sure. So if we could have this slides up somewhere.
We have that to show us.
Check another ACT.
Yeah.
We just for the O3-5R now.
So we'll take a little bit of time just very quickly and go through some considerations in aorta iliac disease. So as we task criteria to stratify aorta iliac lesions by complexity. But more and more, the societies that make guidelines are recognizing that, these are endovascular first lesions, really almost no matter how complex they are. And that's backed up, by data. So this is just a representative example. This is a meta-analysis of 5,000 patients comparing open versus endovascular repair of aorta iliac disease, and showed similar or slightly less patency in endovascular revascularization, but significantly increased 30-day mortality with surgery. And again, at 5 years, fairly similar patencies. And that holds true across, again, all stratifications of lesion complexity. So this was a registry study that looked at endovascular interventions for aorta iliac disease and showed a good, almost 90% primary patency at 2 years. And there was no difference between task A and B and task C and D lesions in terms of outcomes in this registry. When you're talking about endovascular options, there also is, a good amount of data, kind of directing you which way to go. So in terms of PTA versus stenting, there's a Dutch iliac study that randomized patients to primary stenting versus PTA with selective stenting based on certain, post-procedural criteria. This was a randomized study, and it saw basically 6 to 8 year patency of 83% in primary stenting versus 74 in selective stenting. That difference was non-significant, but it's important to note that 43% of the patients that were randomized to PTA in the study crossed over to primary stenting based on the criteria that they had set forth. Other meta-analysis have suggested that primary stenting gives you slightly better patency outcomes as you go years out from the procedure. And so the consensus now is generally, especially as lesions get more and more complex, we're going to reach for a stent more often than not. In terms of your choice of stent, so there's data looking at covered versus bare metal stent, as we all know, the COBEST trial. So this is showing the 5-year data. So there are 125 patients with aorta iliac lesions randomized to covered versus bare metal stents. 77 of those patients were followed up to 5 years, and there was a significantly improved patency with covered stenting in these in this cohort. Again, this is backed up by observational data as well. This was another cohort study that looked at patency of covered versus bare metal and stratified by lesion complexity. And we especially see the difference in patency when we get to the more complex lesions. So again, for more complex lesions, we're reaching for covered stents. Some predictors of failure that have come out. So some situations when you want to be, think hard about going endovascular. When there's external iliac involvement, it increases the complexity of the procedure. When the indication is CLI, that's been a predictor of restenosis with endovascular interventions. Small diameter arteries, female sex, and renal impairment also play into it. And so those are times when you want to think hard about what your plan is. And you always want to keep in mind that a hybrid approach is an option when there's CFA involvement. And there's been, again, some just observational data that shows that the hybrid approach with a common femoral end arterectomy and patch repair with endovascular repair of the iliacs is a very feasible option. So when we're talking about the true bifurcation lesions, the standard of care that was really first described back in the 90s is this kissing stent technique, obviously borrowed from the coronaries. And that has shown good long-term data, just on its own in observational cohorts, and here in this retrospective analysis compared to surgical bypass. So it's certainly a good option and had been the standard of care for a while, but more recently, it's come into question. Do we always need to use this technique when we're treating ostial lesions with only the involvement of one of the iliacs? And there's some observational data that people do okay if you don't do an upfront kissing stet technique. Obviously, as long as you're careful and plan your procedure out well. Now, obviously, there are other ways that the coronary operators have come up with to deal with bifurcation stenting, and the endovascular world has borrowed from them. This is a paper that's describing actually T and protrusion stenting in the aorta iliac bifurcation, with about 20 patients that have very good 2-year patency results. Obviously, that's using bare metal stents. That's just one coronary technique that has been borrowed. I think the other one is sort of this modified SKS, what we call the CRAB technique, where you put an aortic endograft and then place 2 kissing covered stents within the aortic endograft, with the idea that reduces the radial mismatch and maybe improves some of the flow dynamics down through the bifurcation. So this is more and more, coming into vogue. It's being studied with good results. So that's another option with extensive aorta iliac disease.
So I think now you saw the different techniques. So now I think, Raman, what we have to do is first prepare the vessel. So we've chosen a 6.0 shockwave to go in, and you could argue why it wasn't at a 7 and this and that. And
what did the vessel measure as on IVs?
Well, it doesn't matter. The vessel is so tight anyway. Yeah. So what we're planning on doing is just doing a quick 6.0 shockwave here, and then we'll go ahead and decide. Our ACT is 248. Elizabeth gave 500 more of heparin, and now we're going to get this into the aorta. I don't know if it'll press. As you can see, they're barely getting through. Okay, so barely got through. So again, we're gonna attach everything, and then we're gonna go to 2 atmospheres, and then we're gonna go ahead and shock here. So in the meantime, what I'm just gonna do is inject from above, just to see where we are. And I think we have to go a little bit forward. Let me see here.
We are okay.
Yeah, we have to go a little bit forward.
Yeah.
So Gujja is just gonna go I don't think it's gonna go. So I see it's not even going. So I think what we may do is just open it up here. Hold on, put it on coronary, Luke. Yeah. We're going to open it up here, and then we're just going to expand this area, and then move it forward, and then do a second inflation above.
Yeah, this really speaks to how tight this lesion really was.
Yeah, I'm just gonna there it goes. Okay, a little bit of love it went through. So now we're just going to go to 204. So we're going to go to 2 atmospheres. You can see how often I'm doing this stuff. So you can see there's 2 atmospheres here.
It's tight. You can see
it's very, very tight.
Look at that.
Mm-hmm.
Look at that. A napkin ring lesion.
There's 2 atmospheres. And now we're going to go up with the shock wave. Ready? Save that image, Luke. See if that run.
Yeah.
Go ahead. How do you do this? So Luke's going to teach me how to do it. So we're going to press the shock wave. And you can see here it's starting to expand here slowly but surely. And again, part of the problem here is you're on an 014 wire. You really don't have any sort of bailout if you do perforate at this level. So we're just trying to figure out, let's expand this at both 2 atmospheres and 4 atmospheres. Clearly expanded nicely. But at the same time, what's happening with the calcium on the side and how we're going to deal with it? Is there a hematoma or something?
No.
Okay. So now I'm just going to go up to 4 atmospheres, right? I'm going to go to 4. And Luke's going to deliver another pulse again. Go ahead, Luke. Okay. I'm going to do it one more time to fully expand this. And then we're going to run another quick IVUS through to see what we're dealing with, and then we'll take it from there. I mean, the idea here, we still have not decided on contralateral access. I think post this balloon is going to let me know how this is going to behave. With contralateral access, because if you look at that, I want everybody at home to look at this iliac and look at this tortuosity. it's going to be no joke getting an 8 or 7 millimeter balloon up there, or a sheath up there. So if we can avoid it, we're going to avoid it. So
Now,
we're just going to drop the shock wave.
Yeah, so typically with the shockwave, the energy generation is really at the middle portion of the stent. But would you find yourself trying to avoid taking the shockwave balloon all the way across the contralateral ostium to really nail the lithotripsy of the left common?
I think that's the plan.
Artery?
PK is planning to do, push the balloon up a little bit. We had difficulty, right? So I think now.
No, but I think if you look at it, it expanded nicely. I mean, I'm not worried. I think I just need to IVUS this. I think at this stage, I think the shockwave, or at least for now, is done. We're gonna let Luke just kind of take care of this, and put it in the back in case we need to go back. And now I'm just going to pull the shockwave back, which is very, very tight, by the way. So this is very nasty. It's not a nice lesion. There's not a
no, it
lesion.
is not.
There's not a nice lesion you take home to mom. This is not one of those. This is one of those. So yeah, you got to be a little careful here. So let's go ahead with the IVUS. I'm remiss because I forgot to introduce my team, which I always do. I've had a very difficult evening dealing with Dr. Guja, so I want to tell you that, as all of you know, we got Dr. Guja next to me. You got our second endovascular fellow. We're lucky and fortunate enough to have two of the best in the country. We have Luke Murphy, and you met Twinkle last time, Twinkle Singh. We have Elizabeth, our nurse, our lead nurse. And of course, Damien, who's nothing but hustling around here trying to make us look good. So I think we're in a very good spot in terms of people helping us. So now, now we're going to do another IVUS, and we have our excellent Philips team outside looking at the IVUS. So we're going to run the IVUS into the external iliac now. I want to see the status of the external iliac. Okay, as Dr. Guja goes up here, much easier getting the IVUS up into the aorta. Okay, IVUS, please.
It's a tenor vessel.
Well,
common iliac.
Let's see. So this is obviously, you can see the pigtail right next to it there. We're going to do an IVUS pullback whenever Dr. Guja is ready. He's checking on the radial.
He's moving his arm a lot.
Huh?
He's moving his arm a lot.
Okay. Okay, we're just going to run it back. So as you can see here, you got the pigtail in the picture. That means you're still in the aorta. As we come down, distal aorta. There's your iliac. So that's your ostium of the iliac. So I want to go ahead and just take a quick picture there. Flora saved for us to so it's pretty much right at the ostium of the iliac. You can see that there. So measure,
9 millimeter vessel.
Yep, 9 millimeter vessel or so. But come back now. Let's do the whole external iliac.
So the problem will be landing the stent distally.
Yeah.
Distally, the vessel, it's very aneurysmal distally, right here. So we might have to take a shot.
No, here and all, it's fine. It's very calcified. There it is. That's one of the landing zones you have.
Yeah.
But you can see here,
you have another lesion. So you have to end it right here.
And then this is a bigger area.
Yeah. So that's about 10-0.
Yeah, but let's go.
Yeah.
Let's keep going. And I think we have to figure out what we want to do. I just want to see what's happening after the aneurysmal segment, which is just calcified but non-obstructive iliac.
Yeah.
So we just have to deal with the ostium, which is good. Walk it back. Now the question is, how are we going to deal with this? So right now, obviously we're going with an 035 system, so we're done with IVUS. So now we're going to switch out for the 035 supercoil wire, and then we're going to discuss whether we need to get contralateral access or not, which might be an interesting, situation. I think it might be worthwhile to put a 5 French, Karthik. Why don't you get access? And let's put a 5 French wire, and let's see how the 5 French sheet behaves going up. If the 5 French sheet is easy to pull, to push it up, then I think we can rule out, we can switch out for a 6. Okay. So now we're just going to take this all the way up. And now we're going to switch out for the supercoil wire. That's good right there. Okay, good. Wonderful. Supercoil wire, so we have complete access on this side.
If you're planning to use a covered stent, which probably we're going to use.
Well, that's the next discussion, right?
Do we need to balloon protect the ostium? I don't know. I think because it's a balloon expanding stent, I think we might be able to.
Well, that's the question.
Just,
I think let's analyze it once we get the wire up. Before we get access, let's analyze. Let's discuss. And let's see whether we can do it without.
Dr. Guja, you're hitting on a very important level of complexity in this case about what is the best stenting approach, knowing that all the data that Luke had very well gone over.
Yeah.
The question of not just covered versus bare, but even self-expanding versus balloon expanding stents. I think we can agree that given this degree of
ACC, guys.
calcium, that a covered stenting is likely to be the better approach here.
Right.
But now the question is, what about balloon expanding versus self-expanding? I think that's something that we should also discuss.
I think the key here, Raman, is like you said, those are great, but I think first you need to see which image. If you can get a nice landing zone for your covered stent, I think what your point is, balloon versus self, it makes sense, right? So you can see here, it's almost in this view you cannot tell if there's a nice landing zone. Let's go to the other view here. Let's try to open up this iliac to see whether we can actually have a nice landing zone, and then we can discuss. So the advantages of balloon expandable stent that Luke went over are very clear. I think one is obviously, you're able to nail the ostium, right, very well. And you can see here you have a nice view. But the question is, by theory, in order to cover the ostium, you're going to have to have one strut outside, right?
Right.
So the issue here is whether you go ahead and land it ipsilaterally, because you do have a nice angle, but you don't have a nice landing zone.
Yeah.
The advantage of having
looks to be in the aorta.
Aorta is fine though, because the aorta is huge. But the idea would be is you could see here that if we do go with the balloon expandable stent, that you may pinch the contralateral side. So the other problem is if you do bilateral kissing stents, you could see there's an actual branch coming off, a sacral branch coming off the distal aorta, which is going to get covered. And ideally speaking, I don't think it'll cause any clinical concern, but we don't like to lose branches when we're stenting. So I think at this stage, do we do a balloon protection across, or do you want to hit it right at the ostium?
I would hit it right at the ostium.
You want to try that?
Yeah, because the angle is very favorable.
Now I can see the
and
angle.
Also the biggest advantage we have is the opposite side, contralateral iliac is at least 11.0. Right, comparing to
I'm
this
not
side.
worried about pinching the contralateral iliac.
Yeah, I'm saying the aorta is.
I'm worried about jailing the contralateral iliac, because remember, we have to go up and over.
I mean, you're going to get one
strut,
which is probably what it's going to be, but the aorta is also big, and I think it's going to push more towards the aortic side because the pouch is more on the aortic side.
So the other thing, Raman, and maybe Luke can expand on this a little bit. Luke, can you tell us the difference between what makes the atrium stent a little special for us? Not the atrium, the VBX stent. So what size VBXs do we have? Go ahead, Luke. What do you got? You're live. What is the difference between VBX and other covered stents?
I got it.
Okay.
So VBX is more conformable, right?
Right. Yeah.
So you can expand one part of the VBX to a larger size and the other. So for instance, if you don't have to go with the 10.0 VBX here, because you can take the 7.0 VBX and make it a 10.0. And you can also tailor the VBX, where the proximal VBX can be a 10.0 and the distal VBX, or vice versa, can be an 8.0. So if you want to make the ostium 8.0 and the distal 10.0 or 11.0, you can do it. So there's one called as the VBX XL. So that can go all the way up to 16. So when you do this, what happens is it foreshortens, right? It foreshortens. So what do you get? You guys have XLs or no?
We have 8Ls available.
8.0 XL, which goes for an 8 French sheet though. But no 7.0 XLs. So 7.0.
7, I think.
Yeah, but I don't know. What's that distal iliac measure, guys?
10.5, 11.
It's 11.
But it's in the aneurysmal pouch, though.
Yeah, but the point is, we should. So we don't have 7.0 XLs?
No, they only come in 8.
Oh, they only come in 8. Okay. So and that needs an 8 French sheet. Even the shorter ones?
Correct.
Even the 39. All right. So give me the 7.0. 7.0. What do you have? So after the show me the iliac angio. So one of the things you also want to look at, show me the first shot. One of the things you also want to look at is what is the status of the internal iliacs? Because obviously you can go with a much larger stent here and just come across the internal iliacs if you don't have anything to worry about. So C minus, guys, hold on, I'll tell you. VBX 7.0, yeah, 59, that's what I'm thinking. Yeah, so here we go. So this is going to help you a lot, because it's going to tell you what are the status of the internal iliacs and what are you going to do. So right now you don't have to worry about internal iliacs on either side, which is wonderful, which is bad for the patient, but good in terms of his safety for the intervention. So then what we can actually do is come all the way down. Do we have a 7.079? No, that's an 8 French too. Is that an 8 French?
That would be 7 French.
7.0. So give me a 7.079. So what you'd like to do is try to land this as far down the aneurysmal segment as possible, which will then allow you, hopefully, to cover that just into the ostium of the internal iliac, which will then allow, not internal iliac. See, there's a lesion there too? See that? So that's why I think a 7079 is the right size.
No, we definitely have to go across the aneurysmal portion. There's
right,
no doubt
but the
about
question
that.
is, can you reach up to there?
I think
so
we're going to reach probably at that bend, right?
The other option may be able to put a short one up top and then a 7079 down below, because you can see here the internal lesion here, Raman. You see it there, the external internal lesion. So that's another thing.
So the 70 VBX goes until 11.
All right, guys. So give us you know what? Give us a 79. Let's measure it. Give us a 79. So we're going to put a 79 in first.
859 should also go through the 859 should also go through a 7 French sheath. If I'm not
859 goes through a 7 French. Yeah. Oh yeah, you know what? Give us an 859 first.
859, that's a great then idea. We can use the self-fixed bending. That's a good idea.
That's not going to be the L configuration, so that won't be able to go up to a 16. But I think even in this case, we should be okay.
We should be fine, because I think if we decided, it's like one of those things, right? Either you're gonna decide and go with bilateral access. I'm a little concerned after having as much trouble as we did with the arch, and I remember Luke and I struggled a lot doing the intervention of the other iliac. So I think that getting a sheath up there will be very, very difficult.
Now, another part of the question, this is just today's intervention. This gentleman also has bilateral severely calcific femoral popliteal disease. And we haven't seen the angios for below the knee,
but 11,
I would presume that there's also some infrapopliteal disease as well. Would you consider just doing some form of sending almost to preserve your arch for your not your arch, but your iliac bifurcations to make it easier for yourself for next time?
Well, the idea here is to try to preserve the iliac bifurcation. That's my idea. I mean, that's why we're talking about balloon, what is it called? Occluding the aorta and across the ostium of the left iliac in order to be able to get this properly. So my idea here would be, we're not, ideally speaking, the pigtail is low, so it's going to tell Karthik where the ostium is. See, the pigtail comes and hits the bifurcation and comes back every time. All right, that's too high. You'll see in a second.
Yeah.
So we have to really kind of figure out where we are. See, actually, that may be actually pretty good. So you have to hold the pigtail a little bit,
I'm pulling
so we don't trap it. Okay. So Luke, you're going to go up when we tell you.
Flora. One second. Flora, let me pull. There's a lot of. There you go.
Okay. 253 is perfect, Liz. So notice I'm not worried about the distal at all here. I'm more concerned. I'm going to leave it there.
Yeah, it's perfect.
What do you think, Xavier?
That's pretty good.
I think it's perfect. Go ahead, buddy. What's nominal?
Puff again.
Okay. 12 is nominal.
I got it. You can go up.
Okay.
So going now without the balloon protection.
Well, because I think everybody's. I think everybody's. At least not everybody. I'm a little remiss. I don't want to deal with the other iliac stent. So Luke's going to go up here slowly to 12. Yeah, we're good. That's 6. 8. He's going to feel it. Careful. Yeah.
There's 8.
8, 9, 10, 11, 12. Okay, that's fine. I wouldn't give any more die.
No, I just seen.
You've already taken your dump, so you can't do much. Okay, down. Okay.
It's fine. We have a big loop. Pull back a little bit and then go up.
Let's go up to 12. It's fine. Just want to make sure it's up against the wall.
Keep your hands down, Patrick.
12. Down.
12. Yeah.
So now, obviously, we want to make sure that. So one of the things that we do in these kind of difficult lesions is we try not to, detach from the balloon. I think that's a good habit for everybody. You might have to go double negative, Luke. And then what we're going to do is we're going to be able to see how this looks, and then decide. And obviously, the proof's going to be in the IVUS at the end of it anyway. So we're just going to walk this back, and Luke's going to be very careful not to move the stent. Again, I think one of the things of doing these you can leave it right there, Luke. We'll just take a picture. DSA, bro. Let me mag up.
Yeah, we're in DSA.
So again, I think what I really want to see is this lesion. I think we're across the aorta a little bit, but that's okay.
No, you're good.
Perfect.
Spot. Perfect spot.
So I think, we're going to have to, IVUS again, look, don't get fooled by this, guys. IVUS is going to tell you everything. And, and the usual thing is, the IVUS problem is it It's
a
like
little
it's
too
like,
much information.
well, it's like the conscience you don't want to have, It's like if you're a boy or girl, regardless, when you're in college and you get in trouble and you have a
we should
conscience.
have
And,
changed
how
to
that is.
014
So anyway,
that's fine.
so that's the thing. So IVUS is the true conscience. So now I'm going to look at the distal, and then we're going to decide.
Okay. Yeah, we need to change it to an 014
All right. Hold on, not yet.
You want to just post it?
Hold on, boys. Hold on.
I'll
No, I'm saying you want to post it and then
See, the problem, Raman, is when you're dealing with younger people like Karthik, they're always in a rush. As older people are never in a
So
rush.
Raman is younger than me. You realize
I know,
that, right?
but he's an old soul like me. Yeah. So the question is,
I will take that.
Now do you see the mismatch, guys?
Yeah.
This is what I'm talking about. So this is the problem. So now you need to take care of this. So give us a 10-0 or give me a 10-0 or 11-0 balloon, 11-02 balloon. So we need to get this because now this is a likely area for clot or some sort of issue going on. So we're going to go ahead with 11-0 balloon, tack this up. This is also going to anchor this, and this is part of the reason why Luke was very careful pulling the balloon out, because obviously the distal stent is not anchored.
Yeah.
And so you really have to ensure that the balloon comes down as you pull it out, because if the balloon is flailed open, then what happens is it may actually capture, even though it's a covered stent, part of the stent and just move it down, and which is what you don't want. So now also you have to know 11-02. Now also, actually 10-02 first, 10-02. Now also you have to know that a couple of things is, one, that this stent will foreshorten. So some people may have actually gone ahead and placed the stent further in the aorta, anticipating it's going to foreshorten. But I know Xavier is going to correct me and tell me that 11-0 will not foreshorten, right? Very minimal. See, I know my products. So at 11-0, it will not foreshorten. If I try to be super aggressive and take it up further, which I know he's not going to recommend, it may foreshorten. But I think at a 10-0, we'll be very conservative. We want to get it up. And now the question becomes is there a gradient across this external? If there's no gradient across this external, there's no reason to stent it.
Yeah.
So at this stage, if I can get good apposition of this stent, so this way if the patient has a cardiac cath or another peripheral cath, that somebody doesn't get into the struts here, okay? And that's good. Leave it hanging out a little bit. You always want to hang it out a little bit, so this way it wraps up into the aorta.
Go for it.
And then Luke's going to go up. What's nominal here, Chief?
Go for it.
Yeah, well, actually, let's pull down a little bit more.
Five.
Right there.
Go 5.
8.
Yeah,
Go to 5.
I think as you're saying, especially with these covered stents, they're used very often for our iliac interventions. But it's very important to know what you have in your inventory, because having a size mismatch like this in the distal common or proximal external is something that definitely has to be dealt with.
No, it's not a hand.
I think it's very important that everybody, all the interventionalists who are doing these procedures know what the characteristics of their covered stents are.
Go to 8. It's
So
going to
you
hang
can
out.
avoid, possibly having a very large mismatch, because as we pointed out earlier in the case, that there was definitely an aneurysmal segment in that external, which is
right. And I think the advantage of this VBX go to what is nominal again?
8.
No,
he's feeling it. He's feeling it.
Leave it at 8. Okay, down. Okay. Hold on, let me walk it out.
Do you want to take a picture?
Yeah, of course.
Much better.
See, now you're kind of opposed, but you're not really opposed.
I would probably still take it into the vessel and then go up nominal more.
No, I mean, to me, look, I'm not going to get crazy here, but because you have an overlap of the branch, right? So let me just go to another view so I can see a little bit. Okay. Because I have that branch coming off, right? See, this is nicely opposed. See that?
I would go still a little bit more.
Yeah, this is nicely opposed. I mean, you could go to 11 if you want, but he had a lot of pain with a 10, and I think your benefit of getting that is not good. So now what we're going to do is we're going to do a quick IVUS. Let's walk this out, guys.
Take the ostium a little
not with this balloon, no. No, with the ostium, I'm fine. We'll let the IVUS decide. Hold that. So that's another.
Let's exchange it to an 014 over this.
No, I don't want to take this balloon through the stent. Let's not go through the stent. Just side-by-side wire is fine, Karthik. You'll be able to do, huh? He's okay?
Yeah, it's fine. There's a lot
Just
of
check
loop here, so it's still nicely anchored. Yeah,
Sparta cord?
because I kept a loop.
There's a
Yeah.
run through. I can get you Sparta cord.
Oops, I dropped the. Get a
We
Sparta
have a
cord,
question
guys.
for you guys there. If we do find that there is a gradient in the external, and we do decide to stent across
No,
there,
I need a
would
wire
you go
infusion.
with a balloon expandable or a self-expanding stent?
I think at this stage,
tortuosity?
I think at this stage, because you have the mismatch, is what you have. I think a self-expanding stent may not be a bad idea. The problem is you want to have it very
Okay,
smooth.
we have this.
I'll use the Sparta cord.
Oh, wow.
The Sparta cord is much safer than the run through. Let's not do the
Oh,
run
okay.
through. You got a nice loop here, and it'll be fine. To answer your question, Raman, I think the idea would be
Backloaded.
for me is to backload it, is to go ahead and use the
okay, he can move it.
self-expanding
There's a
stent
lot
here
of loop
because
here.
I'm
Last
not
time
really
it was
worried about
tight.
too much
So when
calcium,
he moved,
and it'll
everything
also
moved.
help me with the mismatch. I think the more important question here is, you're going to use a closed cell self-expanding or an open cell self-expanding. I think a closed cell self-expanding will allow for transfer of sheets through this tortuosity.
Easy.
So, I think I don't want to promote stents, but the point is, I think in certain special areas, myself and Peter Ferries, our esteemed chief of vascular surgery here, did some work on carotid stenting with closed cell versus open cell, and we actually found that we had less debris in the filter in the closed cell, so which is nice. So I think that the open cell will also allow for capture of capture of the stent struts. That's the problem. So when you go through with other devices, the stents may cause issues. Just push it up, you'll be fine.
No.
Perfect. Now we got the 014 IVUS. He's going to walk out the 035, and we're going to do a quick IVUS. Can we do it in the same sheet?
Yeah, of course.
Yeah. Wow. But it'll create a bias, but yeah.
No, I don't think so.
Okay, let's see. All right. Watch your hands.
Keep your hands down, Patrick.
So, part of the plan that Luke and I had was to do this extra balloon, but I think, on further imaging and using use of intravascular imaging, it really allows you to make a clear judgment as to where the lesion is. And when you make a clear judgment as to where the lesion is, you can also place the stent. Now, by no means am I saying we hit the ostium. The IVUS will tell us the truth.
Yeah, we're about to find out.
The great conscious will tell us the truth. Okay, ready?
No, don't.
No,
Why are you pulling it?
Because it's going to create bias. I know it's going to have reflection and all that. We'll just take it out.
Also, it'll show the true confirmation of the
Exactly,
stent and the
stent.
iliac as well.
Exactly. All right, here we go. All right, that's all we need.
Moment of truth.
Moment of truth. Record. Oh, we nailed it. Oh, we nailed it. Look at this. Go back and forth. Oh, my goodness. Nailed it.
Nailed it.
Wow.
Nailed the ostium. There's a great baking show, Raman, called Nailed It. It's an awesome show. But anyway, so we nailed it. We nailed it. Look at this. Look at this, bro.
Very
This
well
is amazing.
expanded stent as
Now,
well.
this is important too. Karthik is making sure the distal. There's the mismatch.
Yeah.
See that?
See that?
Look
See
at
that
the
gap in the
mismatch.
You
back?
see the actual.
Can we go
the,
chroma flow?
Vessel.
And so now
Can
the
we stop
problem
and go
is,
chroma flow?
what do you do? No, we got a chroma flow here. Yeah. So you want to see if there's flow
there's
behind the
flow
stent.
behind the
See, there's
stent?
flow behind the stent. So the
behind the
problem
stent
here is if it's a true aneurysm, obviously it'll be a pressurized sac. It's not a true aneurysm. It's
It's a
just you have
posternodal
flow.
dilatation.
You
Yeah.
have just posternodal dilatation of maybe, it looks like 3 millimeters, so we're never going to expand it. So the idea here would be to put another coverage stent across or leave it. I guess we didn't have, you know how you're going to know how to do this? Let's pass an 035 wire through. If an 035 wire goes through.
You can stop.
Yep, stop. If an 035 wires goes through without a problem, then we know that we don't have to post-dilate this. Let's see.
I would post-dilate the ostium.
Is there
Yeah, awesome.
currently a pressure gradient between the sheath on the
Yep,
left
that's-
femoral
Yeah, we're going to
and
check.
the
We're going to
right
check.
radial?
That's a great point. We're just going to check. Take out that wire and just go through just with this wire. Actually, leave it side by side. Let's
This is
go
what I
side by
mean.
side.
It's sometimes IVUS gives you a little bit too much information. Makes you really have to reconsider doing some extra steps because when you see that, it makes you want to go back and make everything look perfect.
Yeah, I totally agree with you. So this is going to be the proof in the pudding. If this goes through, then you know that this loop is of no consequence. Say it's of no consequence. So the space is of no consequence. So I wouldn't do it. I wouldn't bother. I mean, yes, I think you have an issue. I think, you're going to use another coverage stent to be able to take care of this. There's a little bit of a side mismatch
as well.
Yeah, I'm not crazy about doing this. I mean, IVUS-wise, there's no stenosis. We're only actually doing it for the sake of a reintervention, and Luke and I are going to do the reintervention anyway, so I don't think it really matters. So I think with that, I think the only question now is a question of antiplatelet therapy. Luke, what do you think about antiplatelets on this guy? What would you do?
So for the coverage stents, the recommendation is 9 months. So I think
aspirin Plavix, right?
Yeah, that for 9
yeah, and
months,
I think that's a great point. I mean, you see, there is a difference for those of you at home. If you have coverage stents in the iliac, it's or anywhere really in the SFA, you can even argue about the antithrombotic agents, the NOACs, or Coumadin. But right now, in this particular one, we'll go 9 months, and we're going to keep him on Plavix, Luke, or we're going to put him on any of the novel ones.
I think Plavix will be okay. But he's tolerating it so far.
So we're going to go with aspirin and Plavix, and as far as surveillance. We'll do an ultrasound at 1 month, and then obviously clinical follow-up, and then we'll take it from there. So now Karthik is going to do a gradient from the aorta into the left common femoral.
Zero both.
Dr. Krishan, would you take into consideration the use of Xarelto with a 2.5
for this patient
dosing up front?
Absolutely.
Yeah, for this patient I would.
So this is, I think right now they haven't made the guidelines, Raman, but you can see Dr. Guja's enthusiasm. Karthik, tell us what your thoughts are on that.
I really think it works. I mean, it's not, I don't think it works for the PAD purposes, but I think in general, overall, if you look at the MACE outcomes and everything, I think if a longer study is done, I think Xarelto 2.5 will show a big benefit for the patient. I think Compass trial was pretty limited as of now, if you really ask me. I think they can really expand this study.
I mean,
Voyager PAD was looking at the post endovascular patients, and I think actually based off of that data, they were looking to get the approval for post endovascular revascularization, hopefully sometime this week for the Xarelto 2.5 dosing. Which I completely agree with you, Dr. Guja. I mean, the data is very resounding.
You know what I would do?
In favor of decrease of ALI and reduction in MACE.
And male events. So can you show us the hemodynamics, guys?
So there's a gradient of about 30.
You have about a 30 millimeter, 20 millimeter gradient across the aorta into the iliac. So what we're going to now, this is what I would do. I would put the dilator into the 7 French sheath, advance the 7 French sheath into the aorta, and do a sheath pullback. So let's do that. So they're going to find
the lesion is.
Identify whether we have to fix that external or not.
Yeah.
And Elizabeth's worried about his pressure, but I think at this stage, let's wait before let's do the gradient, and then we'll give him hydralazine. So right now we're going to go ahead and do this. So this is going to tell us whether it's in the stent, whether it's in the ostium or not, and then we'll take it from there. Obviously, the nice things about this coverage stent that we have from Gore is that we can expand it, as you just saw. So we'll decide that in a second. The dilator's in?
Yeah.
So it's very important when you do with the dilator, guys, to watch it go through the distal stent, because you can accordion the distal stent. So, and Dr. Guja, will do it carefully. And if he has any sort of trouble, then what we'll do is we'll just exchange out for a catheter and do a catheter pullback. Generally speaking, with this kind of large stent, you can push it through, but he will do it under fluoro just to make sure that we are in good situation, as you can see there. And there's no accordion occurring. Nope, no accordion at all. He's going to go right in all the way to the aorta. And then from the aorta, we will take it down. That's all. Good.
Now we'll start from the aorta. Also passing through without really much of an issue is also very optimistic.
That's an excellent point. So you can see.
I think the issue is not that sac, right? The issue is the ostium, and also the gradient. I think is the external iliac gradient. So that's what we are worried about.
Well, this will tell us right here. Just come slowly. So record, guys. There's no difference here. So nothing in the ostium.
Nothing in the sac. Nothing in the sac.
Exactly as we predicted when we come to the external iliac, you have a 20 millimeter gradient right there, 20 millimeter gradient. So let's take a picture here through the sheath, Karthik.
Yeah.
So again, now, Dr. Sharma, now you know very simple, Ramanji, that you can see you have a good picture here. Now you can decide whether you want to use a covered or a self-expanding.
Yeah.
So let's take a picture. and then let's see. And honestly, I don't know. I'm not too crazy about doing anything right now. We got rid of like a 1,000 mm grade animated nothing. This might be wire bias too. So I'm not doing anything here. You guys agree?
I would not do anything. I mean, that iliac looks a little strange, but if you're coming back to it,
yeah,
I would probably leave it alone for now.
Yeah. Everybody agrees?
Yeah, it would be another very long stent that'll have to extend from all the way pretty much where your sheath is almost all the way back up. And I think we're just going to end up propagating the stent further and further.
I agree. So we're done here. So Luke, great job on the presentation. Great job on the anticoagulation question.
Yep.
And
Very nice
we'll
job,
be
Luke.
done, and we're going to take the sheets out. We're going to follow. And thanks again, Raman. I just want to remind everybody at home that, we've got the New York Endovascular Summit for the first time this year at the ETC Center, August 15th and 16th. And I just want to go over briefly about the summit. 15th. Excuse me. Again, October 15th and 16th. Thank you, Raman. October 15th and 16th. So October 15th will be the first day. The beauty this year is we have multiple live case sites. Obviously, we're doing live cases from Mount Sinai, but we have Dr. John Rumbach, our dear friend from Holy Name, doing live cases for the endovascular side. Dr. Jose Wiley from Montefiore, Dr. Christopher Metzger from Kingsport, Tennessee, and we also have Dr. George Adams from Rex also doing great live cases. Our faculty will always be a mix of international and national faculty, as you know. There may be some virtual lectures because of the nature of times that we live in. But the beauty here is Dr. Lookstein is leading the Venus Symposium, and Dr. McKinsey, and along with Dr. Tadros, Dr. Sista, and Dr. Rahul Patel, they're all leading the Venus side. So you're going to have two floors where you're going to be able to go back and forth. It's going to be very convenient as compared to the old Mount Sinai symposiums that we used to hold. The second part is we're also going to have for the first time an endovascular nurse tech symposium, led by our very own Beth Oliver and Heidi Garcia, as well as our Ray Lascano and Elizabeth Holton and Maricio are going to lead the nurse tech symposium. So this particular one will be a very much of a primer for nursing and peripheral arterial disease. As all of us know, nurses who are cardiovascular nurses are also involved in PAD treatment, and as well as OR nurses are working in outpatient centers and so on and so forth. It's a little bit of a different way of nursing in a peripheral arterial disease patient as compared to a standard hospital patient. Number three is we're also going to have, for the first time, a true podiatry afternoon led by Dr. Mike Treppel and Dr. Anthony Iorio from the New York College of Podiatric Medicine. So this will be a comprehensive podiatric symposium as an update on podiatry as well as wound care, which I think will be very useful for all of our attendees. And this on October the 14th will be the Mount Sinai Endovascular Fellows course. For those fellows who are watching out there, we're already almost sold out. I won't say sold out. There's always last-minute cancellations. So please, apply and come and see us here. You'll meet all of us, and it's a very interactive and fun fellows course.
2 minutes.
And I do want to say, Raman, that all this will not be possible without support from all of our vendors and our entire industry, as well as all the staff here at Sinai. So again, having said that, I think that this is a good situation where we can say goodbye, and we will see you next month.
All right.
Raman, great job on the first time.
Thank you very much. It's glad to be here. It's odd being on this side of the table. But Dr. Grayson, again, thank you very much. We look forward to seeing everybody at our next live case, September 22nd. And we look forward to hosting all of you virtually and in person at our New York EVS Summit on October 15th and 16th in New York City. Thank you. Take care.